This morning's session, we want to focus largely on two issues. First is testing, and the second is PPE equipment, personal protective equipment for NHS staff. And I want to start by thanking Andrew Latham and the technical team in the House of Commons who've made this happen for the very first time, but also to anyone watching this at home to apologise if occasionally we have a technical glitch because this hasn't been done before. So let's start, and we're going to start first of all focusing on the issue of coronavirus testing, which has obviously been much on people's minds over the last week. And I want to start, if I may, with some questions to Professor Yvonne Doyle, the Public Health England Medical Director. And Professor Doyle, if I could just start by thanking you and through you all the PHE staff who've been working unbelievably hard. I know people often thank NHS staff, but the PHE staff have been under equal pressure and doing an extraordinary job. And I know that the whole committee would want us to ask you to thank them, and also to give our very best wishes to Duncan Selby, the Chief Executive of Public Health England, who was due to be giving evidence but is self-isolating and not feeling well. And we obviously wish Duncan and his family well. Yvonne, just before we go on to some questions on testing, can I just ask you some latest medical opinion, if I can put it that way? How many days do we think that you might be able to spread the virus when you're still asymptomatic?
Well, we think the incubation, by the way, Chair, sorry, I should say first, thank you very much for your acknowledgement of our wonderful teams who have been working now for nearly 9 weeks on a 7-day-a-week basis. And I will convey that to them, and I know they'll be very pleased. And thank you for your good wishes to Duncan, who is recovering. So to go back to your question about how many days. So we know that the incubation period, it ranges between 3 to 5 days. And for people who are asymptomatic, that may be that they have been asymptomatic for some period before those symptoms have appeared. So we are still learning, and this is a very crucial issue for us. We're still learning about those who are asymptomatic and actually never develop symptoms. And we think about 30% of people may be in that category. They have harbored the virus. What we don't know is whether they adequately or effectively can transmit. So 3 to 5 days is really where we begin to see people becoming unwell.
When you say the incubation period is 3 to 5 days, what you're saying is that you could be spreading the virus to other people for up to 5 days before you show any symptoms.
Yes, that's correct. And as I say, we're still learning about that. That does range actually over quite a long range, but in the majority of those cases we're now analysing, 5 days is about the period.
Thank you. Yesterday we read about the tragic death of Chloe Middleton, who was just 21. Mm-hmm. Could you tell us how many other people are currently getting care from the NHS who have no underlying health conditions? Perhaps how many people are in intensive care, just to get a sense of the extent to which this is spreading?
Yes, Chair. So our deaths yesterday on our dashboard were over 400, and I think more have come in overnight. So that would probably bring us up to 500 or thereabouts. We have analysed the first 386 deaths to understand a little more about these questions. And 98% of those people who died had some form of other condition. So at the moment, it is very rare for people to die who do not have some other condition. There are a couple of cases that are unknown, but really the overwhelming message is that the deaths do affect those who have other conditions, and in fact, more than that, are much more likely among those, as you would expect, who are admitted to ITU.
But just doing the maths then, if 2% of the deaths are people who don't have an underlying condition, that means about 10 people have died so far without underlying conditions.
So there are 3 who definitely didn't have underlying conditions, and there are 5 who were still following to understand whether they did or didn't. And could I just say, age is a major determinant in this as well, in every question about the clinical profile of cases and those who get unwell and those who die.
Thank you. And could you give us an idea of how many doctors and nurses are currently in intensive care units with COVID-19?
I cannot give you that information, Chair, because what we get is a line listing now from the Intensive Care Association, who give us information about age and sex, but they don't give us more details about the actual people. We will be able to get to that point at some stage. But I did ask my colleagues about this yesterday, and their view is it is rare. I'm not sure there is anybody in ICU, but it is actually rare at the moment for healthcare workers to get seriously unwell, but we have had some clusters.
Thank you. And then just a final general question. Yesterday, Professor Neil Ferguson said that according to his modelling, we should have just about enough intensive care beds in the NHS to cope with the expected peak. Will that be the case according to that modelling in London?
Well, at the moment, as I understand it, there are about 570 people in ITU, and there is much more capacity for ITU around the country and indeed in London, but there's less capacity in London. It is actually, if we kept things the way they are, there would be less capacity in London.
So it's 570 in London?
570 people who are in ITU with COVID in London. And there are some hundreds more ITU beds. Now, I did say if this kept the way it is, it hasn't actually, because there has been a transformation of the way care will be offered both in London and elsewhere, in escalating the amount of capacity for ITU particularly. People will be aware of the purchase of ventilators, of course, but also other aspects. For example, the rate limiting step is the number of staff who can man adequately and appropriately an ITU unit. And I know that that has been looked at over recent weeks, and hospitals are moving to reallocate and reskill and reorientate the staff who are most likely to be capable in ITU.
But just to go back to the earlier question, you're not aware of any deaths of frontline NHS staff to date from COVID-19?
I can't say that. What I can say is that the deaths we have had are very much influenced by age, particularly between 65 onwards, and comorbidities. I cannot say that there is no healthcare staff member in that group, but what I can say is it would be very rare.
Thank you. So let me move on to the issue of testing, and I'll stay with you if I could, Professor Doyle. I just wanted to start with some numbers, because over a week ago, we were told that testing would go up from 5,000 tests a day to 10,000 tests a day within a week. And I've got the numbers here for the last 4 days. It's 5,500, 5,600, 6,500, 6,500. So we're nowhere near that 10,000. And I just wondered what the problem is there.
Well, at the moment, we have capacity for about 7,000 between ourselves and the NHS, and a lot of work. This was first order work over the last month, is to make sure all our labs are working to full capacity, but also to recruit in a number of NHS labs. And now we will have labs going right down the spine of England, starting with Manchester and St. Bart's, but also many others coming in. By the end of March, the 30th of March, we expect to have capacity for nearly 12,000 tests a day. And by the middle of April, possibly a little later, we will be moving to 15,000 and 25,000 by that date, by the middle to the end of April. So we are confident, and we're watching this every day, that our capacity is going up as we had said it would.
So just explain, when the Prime Minister talked about 250,000 tests a day, was that a plan or is that an aspiration?
So there are 4 strands of work on testing. The element for which Public Health England has ownership with the NHS is the 25,000 to ensure that our sickest and hospitalised patients and those with outbreaks in the community are tested. And that is happening right now, and we're confident that will continue to happen. The 250,000 encompasses a number of other elements. There's the antigen testing of 100K tests for healthcare workers, which will work through a system which goes through the Midlands and will be enabled by other parts of the system, like the National Biological Service and DSTL. We'll all help there, but the responsibility for that is the Office for Life Sciences. That will really be first order for healthcare workers, and particularly those in the most risky situations. And then behind that, there's a plan, and we'll have heard it preceded on the media, for 1 million tests, which people can do themselves, on 1 million tests for members of the public. In other words, they will be able to take a blood test and send it back in the post and get that analysed. That is an antibody test, which tells you whether you've had the condition. That is absolutely critical for 2 reasons: to understand what's going on, but also to allow people to return to work. Now, that is well advanced, but not ready yet. We need to be absolutely sure it's a valid test. We expect that to come within a couple of weeks. But I wouldn't want to overpromise on that, and I think the Chief Medical Officer has been absolutely clear about it being right before it's actually put out.
But if I could just go through what he actually said yesterday. He said priority 1 was hospital patients. Priority 2 was NHS staff. Priority 3 was the antibody test. So are we ever going to get back to testing and contact tracing in line with World Health Organization guidelines, so that every COVID-19 suspected case in the community gets a rapid test and all their contacts are traced? Or has that ship sailed?
Well, Chair, to some extent, let me answer that by explaining what we have done. And Public Health England bore this burden really for about 6 weeks, where in the first phase of this, from mid to late January until the middle of March, this exactly was the strategy, that we tried to make sure we had tested and contacted all the positive test contacts. The aim being to disrupt transmission. And the purpose of that was, we hoped that we could contain indefinitely, but we thought that was unlikely. The main thing was to actually move the peak of this out beyond the winter, but also to give the NHS some time to actually prepare for what we're actually beginning to see now. Now, at a point before we stopped that intensive contact tracing, it became clear to us that there were what I call dead ends of contacts, where you had a case, you tried to find the contact, and it just wasn't possible, because that gave us the indication that there was sustained community transition. Nevertheless, we did contact almost 4,000 people up to that point, and that was from about 590 positive tests. The positivity rate at that point, Chair, was 3%. It was a little bit higher for those where we suspected, but it wasn't very efficient, and it certainly wasn't, we thought, getting to the contacts, because it was out there. As you say, in a sense, several weeks ago that ship had begun to sail, but nevertheless we kept going until mid-March, until we were absolutely sure that contact tracing in that way wouldn't work, and that now we're seeing many more people coming into hospital and community outbreaks in places where it was really quite important to contact trace instead and support the LRFs.
I think this is just going to puzzle a lot of people, because countries like South Korea that had the outbreak much worse than us, they didn't stop the testing and contact tracing. They kept it up, and Korea is testing 10 times more people per head of population than us. They followed what the World Health Organization guidelines suggested, which is that you keep testing, contact tracing. So why is our strategy different? Why have we said, actually, there's going to come a point when you just give up on testing and contact tracing?
Well, there is a core of activity that every country is undertaking at the moment. In the East, what was different about South Korea was that these were clusters of cases where the initial sort of transmission was well understood because they were in particular communities, and actually it was quite regional. South Korea also did something that we have looked at carefully, which is they used technology to contact trace using people's personal details, including their bank accounts. And people were willing to convey that information in order to contact trace. And it was quite personal information. We have looked at that, and SAGE looked at it and felt that was not appropriate here. However, we are still looking at applications that might be able to give us some information about conveying between people, precautionary information about you might have been in contact with me, just take care of yourself, look out for this. And that actually is what was really happening with qualified professionals some months ago. That was the nature of contact tracing. The difference was it was easier to identify the contacts. The modeling now says that actually, if you're getting into the third generation of contacts, you would be actually looking at close on six-figure sums to try and find the number of contacts with the kind of social networking that was going on. Could I just say, Chair?
Sorry, go on, please do.
There is one other element of this. The other element of breaking transmission isn't just contact tracing and isn't contact tracing in this phase. It is about social distancing and about shielding. All countries are involved with this, but we have particularly, as you know, taken that as an effective way of breaking transmission, which is the issue about contacts. But we are still continuing to contact trace. We do actually follow up outbreaks in the community.
But I think the thing that's puzzling here is that South Korea is a democracy. SAGE took a decision, you've just said, that doing contact tracing in the way they do in South Korea would be too intrusive. But because they were prepared to take those measures in a democracy, they're actually able to keep all their restaurants and shops open. I mean, your temperature's checked before you go in. So in fact, they've avoided much more intrusive changes to our daily life by keeping up the testing and contact tracing. And I suppose it's the thing that's worrying a lot of people is that it isn't just South Korea, it's countries like Austria, Germany, Sweden that are also doing a lot more testing than we are. How did we allow ourselves to get behind so many other countries? I appreciate we're ahead of other countries as well, but we're certainly not at the front of the pack when it comes to the numbers of tests we're doing.
Well, testing and contact tracing, I think I'd probably separate at this point, because I think the contact tracing is clear at the moment. What the rationale for doing it or not doing it in the way we're doing it is it effective? Is it actually an effective way of breaking transmission? And also, is it effective use of staff? Because there is limited capacity in the field service to contact, hundreds of thousands of people for a positivity rate of 3% when it was actually much more precise. In terms of testing, I think I acknowledge that the testing does need to increase. And this is why there are 4 strands of work on increasing that. The issue I think I'd just raise here also is there is global competition for some of the materials and the equipment and so on for the very large amounts of testing. It's not a good reason for not doing it, but we are in a competitive market. But I think calls out to industry and very close alignment with SAGE and with government has led us to identify the ways in which testing will be most useful to, as we say, flatten the peak and push out the epidemic into a better time of the year.
But just to be clear, you're acknowledging that even though the WHO is saying that testing and contact tracing should not stop, we took a decision that it was not practical. Indeed, we didn't have enough testing kits to do. And so we moved away from testing. And do you think that we are going to get back to testing and contact tracing in the community at all? Or is it now just too late?
Well, sure. If I could just go back to WHO, and this isn't in any way to sound in any way defensive or excusatory, but the WHO is speaking to the world, and where the Other countries may be still in the containment phase. Testing and contact tracing in that environment would be exactly the same as the messages we took on board and did during the containment phase. But here we are in a phase of delay and where there's sustained community transmission. Now, I do think that this is under review every day of the week. And if there are effective ways that actually will help to further reduce transmission that technology can offer when people are now social distancing, yes, I think that will be and is being looked at carefully.
I just don't really understand why other countries that have had the virus worse than us or are closer to China, Taiwan, Singapore, Hong Kong, not just Korea, they have not stopped the contact tracing and testing. We have stopped it. That does seem to be a very different strategy, and that doesn't seem to be what the World Health Organization is recommending. But can I just, as my final question, put to you what some chief executives of trusts have been saying to the Health Service Journal in a survey that was released yesterday. This is from the chief executive of a London acute trust, who said, "We have a huge surge in London. We are going to run out of staff because of self-isolation, plus some staff are now sick." In the Midlands, a chief executive said, "A lack of testing capacity is the biggest issue we face. Instead of growing it, we burn hours on debates about who should get the test." Are we anytime soon going to have instant testing for NHS staff who are currently self-isolating? Because this is a huge source of frustration.
Chair, yes. And I mean, I would just say that, again, to say we have not stopped testing and contact tracing. There are over 80,000 tests have been done to date, and quite a lot of those have been done in the last couple of weeks. But yes, one of the strands of work led by the Office for Life Sciences is about getting antigen testing out to healthcare workers, particularly frontline ones, as quickly as possible. And I would agree with you that that is very important.
Thank you very much indeed. I'm now going to bring in other members of the panel. We'll start with Chand Nagpal from the British Medical Association. Thank you for joining us, Chand. Your comments on the testing issue.
Yes, well, I represent doctors across the UK, and this has been a source of real problems for our workforce. When the announcement was first made to stop testing and contact tracing and to simply self-isolate, I raised on behalf of doctors the impact that would have on our workforce. And literally the day after, we saw large numbers of staff, NHS staff, not coming into work. And remember, at this time of year, it's estimated around 10% of the population could have a symptom of a temperature or a cough, in a non-COVID situation. So we had situations where many GP practices and hospitals were understaffed. The staff themselves who were self-isolating were telling us they felt able to work, many of them felt able to work, but were following the guidance. If they were able to be tested, they would come back to work. Now, we made that point right at the outset, and it just seems counterintuitive that we are reducing our workforce at a time when we need it the most, our NHS workforce. And then on the 16th of March, we heard from the Prime Minister an announcement that healthcare workers would be prioritised, and that hasn't materialised. Now to make it even more difficult for us, of course, the 14-day isolation has added to absence, because we have many healthcare workers who are absolutely fine, but a member of their family, a child, may have a fever or a cough, and they're self-isolating for 14 days. I can't overestimate what this means on the ground. I know of practices where one doctor is trying to provide a service for 24,000 patients. And the same applies in hospitals, and not just doctors, of course. We're talking about nurses, those in the community, those in hospitals. So for us, this just seems an illogical approach.
Have you noticed it getting better in the last week at all?
No, in fact, each day that goes by, there is another member of staff there are more staff who are self-isolating because, of course, the symptoms of a cough or a temperature are quite prevalent. I don't know what proportion of those symptoms are due to COVID, because we're, even in a normal situation at this time of year, there'll be large, as I said, up to 10% of the population has been estimated to have such symptoms.
Thank you. And I know it goes without saying that we all want you to pass on our thanks to your members of the people you represent for the incredible work they're doing. Can I just bring in Dr. Paul Tanto, who is a registrar at Northwick Park, where there were particular pressures over the weekend. Thank you for joining us. I know that you're not on shift at the moment, so we're not taking you off the front line by having you, and we really appreciate you giving up the time. Just talk to us about, first of all, your experiences on the front line. We'll come to PPE equipment later, but particularly with respect to testing, any thoughts that you have?
I certainly echo what Chant has just been saying about the non-knowledge of testing and the diagnosis of whether staff members have COVID-19. To get into the vernacular, if you have a cough and a fever, do you have COVID-19 or do you have an upper respiratory tract infection? At this moment, we don't know. The former requires the 7-day isolation, the latter not necessarily. Now, we have lost members of staff in departments across London who have had to self-isolate for the reasons of their symptomatology. And with the increase in work of COVID, that has an impact on the efficiency of our departments. We have seen a concomitant decrease in non-COVID presentations to our emergency departments, which has helped. But the work required for a COVID patient is increased compared to non-COVID. So any decrease in numbers of attendances has been more than offset by the individual work per patient required. With a decrease in staff, that is putting a pressure onto certainly emergency departments, but it cascades to the rest of the hospital too, because there are members of staffing in the ward areas who are also going off sick with self-isolation requirements because of potential COVID symptomatology. If we knew that somebody had COVID, fine. If we knew they didn't have COVID, we wouldn't need the 7 days, we'd have less sick power, and that would change sick time, and that would change our staffing issues within hospitals. I echo his comments.
Thank you very much. I'll come to you a bit later, Paul, if I may, about the general situation in Northwick Park. But can I just bring in Catherine Henderson from the Royal College of Emergency Medicine? Thank you so much for joining us, just for your comments on the testing issue.
We're very keen to get staff tested as soon as possible. I've currently got 6 members of staff off with symptoms and 10 members of staff off self-isolating. So it would be really helpful to get those people back on the front line. The ability to put people into hotels when they discover that a household contact has symptoms has been helpful. We're managing to do that, but not everyone obviously has that possibility of going to a hotel if they've got family responsibilities. So from our point of view and around the country, everyone is saying that rotas are becoming more challenging because of this. That being said, given particularly that we're not quite sure about asymptomatic transmission, we need to continue with the quarantine arrangements, the self-isolation arrangements, until we do actually have the ability to do the testing. We're not pushing for bringing back people early just because they feel okay. We would be pushing for having people back early because we've tested them.
Thank you very much indeed. I'm now going to bring in my colleagues from the committee, and I'm going to start with James Davis and then go on to Amy Callahan. So James, who would you like to ask a question to, and please fire away.
Professor Doyle, if that's okay, at least initially, in terms of testing and in particular of key workers, we've heard that more sites around the country are being brought on stream in terms of testing. We've also heard that there are issues in terms of acquiring elements of the test kits, and that we may not be top of the list nationally or internationally, sorry. So my question really is where you would place the various factors that are limiting the ramping up of the testing. Is it the sites or is it the equipment? And if so, why are we unable to put ourselves above some of the other countries that are perhaps doing better in that respect? also wondered whether there's any data from other countries as to the numbers of asymptomatic patients out there, those that are doing more testing. Thank you.
Yes, so to answer the question, there, as I say, there are three active elements really, and a surveillance element about the testing. The one that Public Health England works with the NHS on is the 25,000, moving to 25,000 a day, which will be for patients and for outbreaks in the community. And if there's spare capacity, absolutely the next priority behind the patients are the frontline staff. But we understand that that won't be enough for frontline staff, and therefore the Office for Life Sciences has been asked to develop a much greater capacity, and we're supporting that. And all I can say is that is progressing, but I am not able to give you the absolute day that that will come up to 100,000 antigen tests. And yes, we are in touch with other countries. In fact, we ring all our contacts around the world several times a week, including in the East. And we do know the differences about why certain countries have taken the line they have, or how they're actually measuring what they're doing as well. We are well placed because of our scientific base, our contacts through that with industry, to get the kind of equipment and materials that we need. But all I would say is it is a global market and everybody wants this at the moment. And I do know that WHO are also concerned about this.
Thanks. James, any more questions from you?
Well, I did have one further question about the home test kits. There's been a suggestion that these will be performed by people themselves and sometimes will give readings there and then. Are we going to, or is it suggested that we should rely on self-reporting of tests rather like we do for pregnancy test kits or for blood glucose monitoring for the purposes of recording in medical records?
Yeah, so self-testing, as you say, is not new and is well understood in other areas. And I think there's been fast learning about how that works. I mean, obviously, the most obvious one is the pregnancy test, but there are other areas as well. And the intention is to allow people to do as much of this as they validly can. And that's why the validity of the test is important if we're asking people to self-test. But it is by far the most efficient way if the technology will support it.
I'm going to come on to Amy and then Rosie Cooper. If you've got more than one question on testing, could I suggest, colleagues, that you ask them all together and make sure you remember to say who you want to direct the questions to. So Amy first.
Thank you so much. I'd just like to echo my chair's thanks to the panel for answering our questions today. It's really helpful. I just have one question on testing, and that is kind of around the home testing kit again. So Professor Chris Whitty had stated that the second priority behind testing those in hospital is testing NHS frontline staff. And then the third priority behind that is then the home testing kits potentially. But 10 days on from the Prime Minister's announcement of testing for frontline NHS staff, we still don't seem to be much further forward. So I'm just wondering what the reality is of these home testing kits coming into fruition anytime soon would be. And I think that's probably directed for Yvonne Doyle. Again, sorry.
Thank you.
Yes, thank you. I understand why. And yes, so I know this is not my responsibility, I have to say, but so you will have to take it as what I am informed of. But I know that the healthcare workers are absolutely the priority now. And this is very active. I'm unwilling to give a day when this is coming on, but it is imminent, and certainly the kits are available and the testing is understood, and the intention is to get it ramped up as fast as possible. I do understand what other members of the panel have said. We're experiencing, of course, this in our interactions between ourselves and the NHS. So I fully understand and accept that.
To Rosie Cooper, and then after that, Paul Bristow.
Thank you. My question's directed to Professor Doyle. Professor Doyle, despite the fact that case finding and contact tracing in the community is known as best practice, and even the government published a paper demonstrating the effectiveness of these methods, we seem to have totally disregarded that and are on a path all on our own. The question I would like to ask you is, I've heard from other MPs that they have manufacturers in their constituency manufacturing tests, and they themselves were absolutely astounded that they were exporting these tests around the world, and yet no contract had been placed by the British government. Is that correct? Do you know that? And I suppose the next bit of that is, when was the first major contract for testing kits placed? And I think I'm going to speak rather strongly when I say that a lot of people have expressed, both NHS workers and the members of the public, have expressed the view to me that they think the government has lost control of this, is completely overwhelmed, and is now bunkering into the bits they can do, and have stopped dealing with best practice. They're horrified at where we are.
So just to answer again, for the part of the testing that Public Health England and the NHS are responsible for, we have been able to give a commitment that those 25,000 tests a day will be on stream by mid-April.
No, that was not my question. My question is, when did you place the orders? Why are we so far behind the curve? Did we actually export tests from this country without the British government having placed those contracts for us?
I can't answer that about contracts being placed by the government, I'm afraid. But what I can say is that...
Or NHS England, whoever.
Yeah, I understand, yeah, and we work together. But let me tell you what I can tell you is that a call to industry has gone out some time ago and did get a good response. And those who could... This isn't about really whether... It's not to do with money, and it's not to do with trying to bunker down. It is about whether the responses actually will deliver what we need to happen, which is a huge increase in the capacity for testing, which we know about, and also the way it's done. So all of this is done in conjunction with the scientific advisory committees, and this follows their clear advice. And that is in progress. That's all I can say. And it is promised as imminent.
So we know better than the World Health Organization. We know better than public health professionals right across, who are astounded and disappointed in our response.
Well, I don't think we're trying to say we know better. We're in regular touch. I mean, we were in touch with the WHO only yesterday, and several of our people are working on this with the WHO.
So which bits of test didn't we get?
I'm sorry, Ms. I can't answer that question specifically, but I think, you know, if you wish, we can take that away and request the parts of government that might know that answer to provide that for you. I'm happy to do that. But in terms of the WHO, I'd say again, at the moment, there is a profound attempt to reduce transmission. That has been informed not by trying to bunker down, but by the information we've had from SAGE, that this is the most effective way to protect the most vulnerable. And contact tracing continues for outbreaks where it is extremely important, where people are contained, for instance, in nursing homes, that we do actually follow it, and prisons. We do follow as best we can where that came from and do something about it. And that is active at the moment. So we haven't diverted from the WHO. We're simply in a phase where this is the most effective way of
Rosie, Chand wants to come in, I think, on that point. So can I just bring in Chand?
Yes, so literally 3 weeks ago, I think we had about 20 cases, and we have several thousand and probably a doubling every few days. I just want to understand how valuable it will be for this to come on stream in the middle of April. That is, 3 weeks away, by which stage the numbers we're likely to see will have grown exponentially. And I just want to understand how it can be of value for healthcare staff to be waiting that period of time, and at the same time we're being told it will be imminent. I'm just not clear about the timescales, because what I'm hearing is the middle of April, and we'll be in a completely different situation then, and so many healthcare staff will now by that stage be infected, and I'm not sure how contact tracing or testing at that stage will be as effective as doing it now. I accept the logistic issues.
Professor Doyle?
Tracing goes, again, I would say that we continue to contact trace long after it was felt to be effective. And I just repeat what we found, which was the actual positivity in the contacts was 3% of thousands that we followed. So it would be much less now. However, we continue to look at whether contact tracing has a place at this point of transmission, where, as I say, many, and this has been modeled, John, so it isn't, you know, simply something that we've made up to be convenient for staff. It's been modeled that actually the gaps between the cases who have this and where they might have got that up to the point of social distancing were unknowable, almost unknowable, because of community transmission. And to some extent, although we're very positive about what happened in the containment phase, the fact is containment cannot run down to ground every contact, as we're now seeing.
Thank you. I'm going to bring in Dean Paul Bristow and then Dean Russell.
Thank you, Chair, and thank you to all of you, especially the frontline NHS workers for what you're doing at this time. I'd like to ask two questions, if I may. If a hospital doesn't have their own testing facilities or their own laboratories, how long does it take to get test results back? And if there's a capacity issue here, I'm just wondering whether you just might explore it. And secondly, some hospitals, I understand, are refusing to allow a patient to be tested for a second time, regardless of a change in their symptoms. And the reasons I'm addressing this is some direct feedback that I've received. And the reason I ask that question is that if a patient is suspected of having COVID-19, they're often placed on a bed, or they are placed on a bed, next to patients who definitely have COVID-19, and then are moved on to a clean ward after a negative result that might come, several days later, despite being next to this patient for a considerable period of time. So I'm just interested in your view, if that is, if that policy is happening throughout the NHS, and perhaps the views of some of the NHS frontline workers on whether they've seen this activity.
Well, if you wish me to answer first, and then I'll pass over to colleagues. So the testing still continues. As I say, 80,000 tests have been done, and much of that is orientated on hospitals, and it would be a clinical decision as to who to test. Where we have provided advice, I think through SAGE and through our infectious disease consultants who watch this, is what is worth knowing about tests. When is it worth doing several tests, and when does it really not tell you much more? And that also is being done in conjunction with the increasing knowledge about the clinical profile of this condition, where we know for the majority of people they will be better in 7 days and less likely to transmit. That isn't the case for people who get severely ill and who have to be cohorted or into ITU, where 14 days onwards is much more likely. So I think as we're understanding more about the clinical profile, it does inform when and what is best way to test, but it would be a clinical decision, and that's what the testing capacity is being increased for. But maybe I could pass to
So just specifically on the question about how long does it take? So say you're in a hospital that doesn't have
yes, I'm sorry. Yes.
How long would it take for that to come back to the hospital?
Well, I think that might vary by region, but the test was taking up to 5 days to come back with the result. And I have to say, I do think that was too long, which is why it is important that we increase the efficiency of the results.
And what's the capacity issue here? Is it a microbiologist capacity issue? What's the issue there? Why is it taking so long?
Well, initially, I think it was just it wasn't actually the time it took to do the testing, because at that point, Public Health England was doing all the testing, and it was done in 4 hours. Much of it was, and we did analyse this, much of it was about the time it took to get to the hospital or to get back. And at that time, there were quite complicated ways of informing people, and it went through various databases and so on, and had to be validated, because the worst thing was giving people the wrong result. So that it was on that end that actually the days on either side, and particularly I think the bit after the test was done, And we really have worked to try and improve that. But I do accept that was too long.
And sorry, just I'm sorry to labour the point, but is it? What about laboratory opening hours? 24 hours. Are they open 24 hours? Have we done that? What about weekend practice working? Because I know that has been an issue with other before COVID-19. That was an issue for things like sepsis, etc. But because of this particular emergency, do the labs now open all the time, basically?
Well, I can speak for our labs, and they've been open 7 days a week for the whole period of this. They moved very quickly to 7-day week. They work overnight. The tests actually are done overnight.
Dean Russell and then Luke Evans.
Thank you, Chair. And this is directed towards Professor Doyle, I'm afraid, for you again. Another question. Two related questions, really. First of all, I'm speaking extensively to pharmacists across my patch in Watford, but also Hertfordshire and wider. And they're really concerned because they see themselves as very much frontline. And so they're concerned that they're not getting tested, and actually a lot of GP surgeries now are only taking calls before patients can walk in, whereas pharmacists are having people walk into their stores and into their chemists and seeing them directly. And I think there's a real worry about that, and I'd love to know whether you're considering pharmacists and also people like dentists as well within that frontline group and the urgency of that. And the second question on that, just related again to the testing question before. What I don't quite understand is that we've put a call out to factories for ventilators. Why aren't we putting a call out across the country for more organisations to open up their doors to help do the testing kits and build the testing kits and help support the testing? I understand it'll be more complicated, but my grandmother helped build Spitfires in the Second World War, and I'm sure she didn't know how to do that beforehand. And so I'm sure people could learn how to do the testing and allow us to do even more than 25,000 a day, because it seems that this is the most imminent thing that could help us.
Thank you. So on the pharmacy, again, the NHS would be well informed about this, but I do know as key workers, they're considered as such. We have provided guidance, which is part of our responsibility to advise people as frontline workers, including pharmacists and dentists, what they need to do to keep safe and to protect their patients. And I know that pharmacists are considered very much part of the solution to elements of how we get through this epidemic. Certainly so. I think that might be one the NHS might want to elaborate on, but we certainly have been involved in providing the guidance, and they are very...
Sorry to interrupt. Yeah. If I may, though, can I ask specifically around testing? Will they also be considered, as we can ramp up the amount of testing we do, they will be considered part of that first tranche of frontline energy?
Very much so. If they're involved in the COVID response, very much so, yes. And as far as the call to industry, absolutely. I mean, this would be absolutely what we would love to see. And calls have gone out to invite anyone really, and we get a lot of people approaching us, and we put them through to the right quarters to make sure that their offers are duly considered. So there is a great willingness there to get the solutions. That needs also to be balanced just about, as the Chief Medical Officer would say, about making sure that what we're offering is valid and works in this situation with the novel variant.
And may I ask on that as well, has that call also gone out not just to business but to universities? Because there's universities up and down the country with quite impressive laboratories. I'm a former physicist, and I used to work in some of them, and I just wonder whether those are being activated as well to enable the testing, because as I could imagine, there's an awful lot of medical students and students across the country that could become an army of people building the tests, but also performing the tests.
I understand that not just retired, but medical students and indeed nurses in their last period of training have been invited to contribute in the most appropriate way. And the universities, yes, so the Office for Life Sciences, which is involved in some of these testing processes, are very well connected to the universities, and the universities have been certainly mentioned as part of the possibility of offering solutions if they are set up to do so.
Could I possibly just ask my colleagues, because I'm very keen to have enough time to talk about PPE equipment, which is so important for staff. If you could just ask all your questions in one go, so that we can make sure we have enough time for the protective equipment discussion. So Luke Evans and then Taiwo Owatemi.
Well, I've got, thank you very much, Chair. My questions are to Yvonne Doyle. They're quick fire questions, if that's all right. Can I just ask, is it a PCR cheek swab still, the main testing we're doing?
Yes, so it is PCR. It's throat, yes, throat swab, actually, yes.
Thank you. How much does it cost?
Well, the actual test is the test that we do is very cheap, but the kit and the delivery and so on, I can't give you an exact figure, but I know it is considerably more. It's somewhere in the order of £70, but I couldn't validate.
Sure.
I would have to find that out. It's an NHS number.
And so, if we assume then close to £100 doing 25,000 tests, we're getting close to 2.5 million a day then, if we're wanting to be able to do that. Whose budget's that coming out of, and have you got enough there?
Thank you. So there is a national COVID government budget, which everyone has been invited to avail of. Obviously with the right governance, and certainly in Public Health England, that's what we do, and we are not concerned about budget cuts in this particular incident.
And then in terms of resilience, the key thing is being able to do the test, but having the staff to be able to do that test. What plans have you got in place? Because if you lose 20% of your lab technicians or histopathologists, how are you going to cover that?
Yes, and this is a big project across government, is to understand what we would do for business continuity in the context of 20%, and that was understood very early on from the modelling. And it is a massive assessment of skills and deployment of skills in flexible ways to as close to the front line, and certainly in my organisation, as we can get people safely. So it is a huge endeavour, and you're absolutely right to say that workforce is a rate limiting step.
And then my final question then, Guys, Kings and Tommies have released a research app basically aimed to go out. You report on the day if you are well or if you have symptoms. This seems a very sensible way of being able to track the spread if we get people to use it voluntarily, giving some updated data. Have you any thoughts on that? Has there been any discussion about possibly rolling that out on a wider scale to see how this spreads and people self-reporting?
Well, this is part of the offers. These are parts of the offers that we really welcome. And I certainly am aware of Kings and Guys having offered us something, as have many others. And I never ignore those. If they come to me, I make sure they go through the portal where these are examined as to what utility they might have, and, you know, are they the right thing to use? But we welcome it, and these are where the solutions will come from.
Thank you. Taiwo, and then after that, James Murray.
Thank you, everyone. My question is actually directed to Professor Doyle. And it was just 2 weeks ago I had to self-isolate because I had some cold symptoms. It took about 2 days for I contacted Public Health England, who told me that I'll be contacted by I contacted NHS 111, who said Public Health England will contact me. That took about 2 days. When I was contacted, I had to go to the drive-through, and that took about 5 days to get my results back. Just wanted to know if this process has improved in terms of reports, considering it took 7 days all in total for me to go from reporting to actually getting my results.
Yes, I can. And first of all, I can indeed. And I hope you're recovering, and thank you for sharing that. It's important to hear this. I wouldn't try and say this was a good experience for taking 7 days. It's part of the answer I think I've been giving about we really need to get much faster about getting the results back. I think perhaps at that time, I will take back your experience about taking 2 days for Public Health England. It may have been that there was a lot of activity going on, and the relatively small teams. I mean, we have 70 people and about another 120 around the whole of the country trying to do this up to the middle of March. So small numbers of people, but very committed to getting to you. So I'm sorry it took 2 days, but I know they were committed to doing it. And then the 5 days afterwards, I would much rather that this was actually within 24 hours. I would like to see that happen. And I would hope that as we move to bigger capacity and perhaps quicker technology, we'll be able to do that. But it isn't the test itself that's taking the time, which I know is frustrating to say. It is the logistics of what's happening, particularly after the test has occurred.
Okay, thank you. I said thank you, Taiwo. Do you want to come back on that, or are you happy if we move on?
Yeah, I was just gonna ask what information is being provided to the public to put them at ease, especially if you'd have to wait a couple of days for you to be contacted by somebody, because NHS one-on-one was not as helpful as I thought they could have been, and I understand that they don't have necessarily that information to provide.
Yes, and I think I'm glad to get this feedback. So at the moment, our helpline is getting about 25,000 calls a day, and that varies. And sometimes that comes through NHS 111, so it's a diverted line. It could have been NHS 111 itself. I know they have huge numbers, depending on what comes on the media on the particular day. So I would like that to be, always, I would like it to be a better experience. So I'm glad to hear that, and I will feed that back.
James, Laura wanted just to come in on that very point, if you don't mind holding on one sec. So Laura Trott.
Thank you, Chair. I just have one specific question that I wanted to ask. Many of my colleagues have talked about the length of time it takes for the test to come back. So I just wanted to ask Professor Doyle, there is a point of care test, which is with the MHRA at the moment, which will allow clinics to do that at the bedside, and the results will come back in about an hour. What is the delay in this being approved, and how quickly can that be forced through? Because it's something that a number of clinicians in my patch are asking for.
Yes, again, it's something I will need to take to request from the NHS, because we're not actually the people who do the point of care testing or responsible. The NHS will be. But Ms. Trott, I'm sorry I can't answer you directly, but I'm very happy to come back to you on that through the NHS.
Thank you.
Thank you, Professor Doyle. James Murray.
Thank you, Chair. And my question is for Professor Doyle, which is that there does seem to be a disparity between the WHO instruction about test, and the approach that we're taking here in the UK. And I'd just like to understand a bit more where that different approach has come from. Can you say, is it entirely down to the capacity? As in, if we had unlimited capacity, hypothetically, in terms of how many tests we could do, would we be aiming for more than 25,000 quicker?
Well, we are aiming for more than 25,000 quicker, and in the circumstance of increasing capacity rapidly, Mr. Murray, we had to prioritise where the testing was most important to do and how quickly. But the intention is actually, as we've said, to get the healthcare workers next in line, and then critically to understand what's going on. And this technology has to be fully validated. But the most critical and the game changer will be the antibody test, which tell us which parts of the population are immune. And on that, we're in complete agreement with WHO.
And I think I appreciate absolutely the prioritization in terms of patients and NHS workers to prioritize the testing which is available. I guess my question, just so I really understand where the decisions are coming from and on what basis they're being taken, are the decisions about testing limited entirely by the capacity to test more, or are there other decisions being taken for clinical reasons, strategic reasons, political reasons, and so on, to have a particular approach in terms of the testing numbers?
Well, always the approach through this whole epidemic is influenced by the modelling and the science in the first instance, and then senior clinical advice and Public Health England's guidance. That's what sort of directs us as to what we do at any particular phase. And the numbers, of course, because this is a critical thing. Our surveillance will tell us what is actually going on in the population at any time, and in the light of that, what interventions are most likely to be effective. And I continue to say that testing is part of a general approach to this. It's not, the whole epidemic will not be sorted simply by testing everybody. I understand what people say about the East and so on, but you know, in China and in Singapore, and we're in touch with them, and in Korea and in Japan as well, testing is part of a portfolio of interventions, most of which you're seeing at the moment. Yes, undoubtedly, we would like to have more capacity, and that is something I think has very clearly come out this morning, that is the intention, to have more capacity to test. But on its own, testing, or indeed just contact tracing, is not in an epidemic going to actually protect the population to the maximum effect.
Okay, so just to
Sorry, go on. Yes, James.
conclude that, just so I make sure I've understood it correctly, you're saying that you would obviously like more capacity, but the decision around the strategy in terms of testing is not driven entirely by the capacity, it's also driven by other decisions, whether that's the overall clinical priorities, whether that's political decisions, whether that's a decision about what strategy you take, irrespective of what capacity is available. Is that correct?
Yes, and in this order, I think the science and the clinical reasoning and the surveillance and the numbers first, and then the decisions about what is the best thing to do at that time. And I think, and also very much about, you know, what is realistic, but we've had a very coherent cross-government approach to this, which really is a whole country attempt to do the best that can be done under the circumstances of what the numbers are telling us.
Thank you, James. And last but not least, thank you for being patient, Sarah Owen.
Yeah, and thank you to the panel. I have two questions for Professor Doyle first. The first one's around NHS workers, and I'm really relieved to say that they would be treated as a priority for frontline workers for the testing. I wanted to clarify whether that would include ambulance and paramedic, as well as social care workers as well. And the second one is around the antibody tests. And I think you just alluded to it just then. What evidence do we have that having caught COVID-19 or coronavirus and that you test positive for the antibodies, what evidence do we have that it actually provides immunity, and how long will that immunity last for? And if we don't know, what purpose are these antibody tests actually providing? The second batch of questions goes to Dr. Nagpal, and that's around something that the professor said earlier on around, she repeated, age is a factor. And if this government is asking retired doctors, nurses, healthcare workers to come back and play their part, what risk is that causing for your members? Have you had conversations with the government around that? And the last one is around pregnant healthcare workers and doctors. We're seeing a large number of reports of pregnant healthcare workers feeling pressured to go back to work or to continue working, when actually the government advice is for pregnant mothers to isolate.
Yes, thank you. So yes, ambulance work is very much, and paramedics at the front line dealing with people in the community and in hospital, very much part of healthcare worker priority. And the question about immunity, so it's a novel virus. So we have to really model it and learn about it clinically on the basis of 3 previous viruses. First and foremost, pandemic flu. But also you'll have heard it called SARS because it is of that family, and the Middle Eastern virus, which is mainly, as its name says, contained in the Middle East, but has been quite severe and has appeared in other countries. And what we've learned from that is that immunity is certainly strongest in the first while, in the first few months. We can say with some confidence that people would be immune at 28 days. Whether we can say that they'd be immune in a year or two's time is not possible to say at the moment, and it's one of the important scientific questions that SAGE, the Scientific Advisory Group, is looking at. And then to answer your question, so what does antibody testing tell us? It will tell us, as I say, 2 things. It will tell us who actually cannot, very unlikely, I won't say cannot because we're still learning, but is highly unlikely to transmit infection, which is important because that allows people to get back to some form of normality, including work. And it also tells us about what is going on in the population in terms of seroprevalence. That's not the sole purpose of doing antibody testing, but a proportion of the testing will look at what is going on in the population so that we understand much better what this epidemic is doing.
Thank you very much. Chand.
Yes, so the question about age and retired doctors. So about 15,000 retired doctors were written to by the General Medical Council, and they have been put onto the medical register unless they wish to opt out. And significant numbers, over 2,000, have indicated they wish to support the NHS at this time. It's really important, as you mentioned, that they are protected because they are in an age group that puts them at higher risk, and many will have other medical conditions. There are significant areas of work that are non-patient facing. For example, in general practice, we're able to manage a significant number, maybe over half of our patients through telephone consultations. You heard about NHS 111 having, in my patch at least, about a 5-hour delay for a response. So retired doctors could be very useful in providing medical expertise in that sort of area. And of course, many other patients in hospitals are also managed in a non-patient facing way, increasingly with video consultations and follow-ups remotely. So there is a role for them to play. Having said all of that, where they are going to be treating patients, this will be the second part of today, of course, is that it's vital that they have the right protective equipment, as all of us must, as doctors, have the right protective equipment, all healthcare staff, and that I know we'll be coming on to shortly.
Thank you very much indeed. And thank you everyone for those questions. I just got one final question on testing to Professor Doyle. I'm sorry you've been getting nearly all the questions, but you appreciate what an important issue it is. At the start, you said that you could pass on the virus when you are asymptomatic or potentially up to 5 days. Does that mean that today NHS staff are likely to be passing on the virus to their patients?
So, Chair, this is something we're learning about. In theory, people should, when they're incubating viruses, they can be infectious. We still have to chart the nature of this virus and how infectious it is and at what point. So we're working here on first principles that it could be, and that's a precautionary principle. People tend to be most infectious. We've noticed this from the testing and indeed from the clinical feedback we're getting from colleagues. They're most infectious at the beginning of this disease, particularly if they're severely unwell. And that does tail off. And that's the issue about what happens between 7 and 14 days. Other important things do happen between 7 and 14 days for those who are hospitalized. So yes, the answer in theory is yes. And at the beginning, particularly when they're symptomatic at the beginning, they may be at their most infectious. But we're still learning.
Thank you. So if the answer is yes, can you give us some date when we will be able to introduce for sure absolutely rapid testing for all NHS staff? Is there something you could say to NHS staff today that would give them some comfort, that by this time next week, everyone will be able to have tests on a regular basis. We'll be able to turn around tests for NHS staff in 24 hours. Is there something you could say, a message you could give them that would give them some comfort on that?
Yes, I mean, the comfort I can give them is that this is the most active work that is ongoing. And as I say, unfortunately, I am in the NHS. It probably would be good if the NHS were alongside here. But, what I can do is ask that question to the NHS, would they wish to give that assurance? I'm sure as soon as they have a time that this can be put into the public domain, they will do so. And it is very active. But I think it would be disingenuous of me, not in the NHS, to give a date and a time which simply would raise people's hopes and then might be found to be inaccurate.
Okay, I understand that. I mean, Public Health England is in charge of testing, and so that's why we think it's reasonable to ask you that question.
Yes.
You can't give us any sense, because obviously the discussions you're party to, we're not party to, but you can't give us any sense as to when it feels to you like NHS staff will be able to get immediate tests.
Well, in the first instance, our labs do about 1/3 of the testing of the 25,000, and the NHS is the major capacity in testing, even within the system we're describing. And then we're talking about adding on further capacity from industry. So I'm not trying to excuse this, but I just say we are a small partner in the actual testing. And we are also, of course, having to test for many, we also are the guardians of other infections. So our labs are not just waiting for COVID, they're very busy all the time, as indeed I'm sure the NHS is. So that is what I can say, is that we are partnered with the NHS. We do provide the advice and the technology and the know-how, but the capacity is something the NHS really brings to the table.
Okay, thank you very much. I'm going to move on now to the issue of protective equipment for staff, which has obviously been very hotly debated in the last week. And I think what I'm going to do is start by just asking Dr. Paul Tanto to talk about his experiences on the front line and what his colleagues are saying to him about the issue of PPE equipment.
Sure, of course. Certainly, I'm keen to point out, as is my trust, I'm speaking in a personal, professional capacity as a doctor working rather than speaking for the trust. Personal protective equipment, we've had several iterations of advice of what is the appropriate PPE to be wearing. Obviously, it's a novel virus, it's an unusual situation. Most of us have never, I think all of us have never worked in a pandemic situation before. So there's a degree of learning as we're going along, what is the appropriate level of PPE. This has caused a certain degree of confusion, I think, is inevitable. And I think sometimes the communication about what we should be wearing has been a bit slow in coming forward to frontline NHS staff. Thus, at the start of our preparations, we were using Ebola type PPE, whereas now we've downgraded to more appropriate PPE on the basis of the infectivity of COVID-19. The availability has been mixed. It's largely present in terms of the appropriate PPE, but there are certainly occasions where we run short of equipment. Visors certainly have been an issue initially, though I gather that with the establishment of the central distribution mechanism that that's no longer going to be a problem. Gloves and gowns, not so much. It's an issue less, I think, in hospitals and more in our ancillary services and primary care situation, where the PPE equipment isn't being distributed quite as efficiently as it could be. Staff are rightly concerned about the degree of infectivity that may occur with PPE, but we are reassured by our occupational health teams and our infectious diseases teams that what we're wearing is appropriate to prevent onward transmission from patients to us and vice versa, where that occurs. As ever, it's a communication issue. Divergent messages do create difficulties because people will always look to what suits their own perspective on the situation. Whereas if we have unambiguous, these are the equipment you require, and it's an absolute across our service, I think that will reduce issues about, I don't have appropriate PPE. I think we've all seen some of the PPE discussions on social media where some people said, I don't have PPE, but yet it's the PPE that's appropriately deployed in other environments. I think it's a continuity of communication, really, primarily.
Okay, thank you very much indeed. Can I bring in Professor Henderson to talk about what your members are saying at the college?
Thank you. You've just promoted me to professor, so that's very nice. Mere doctor, I'm afraid. We really want to stop the chain of transmission. That's the really important thing. And we're very worried that the situation that we're in is not stopping the chain of transmission with a group of patients who are potentially at risk. So we've heard from Professor Doyle that there is the possibility of asymptomatic patients, which means that any patient who's unwell enough to be coming into an emergency department at the moment needs to be considered as having COVID-19 until proved otherwise. In which case, even in our cold zones, in our low risk areas where patients are coming in, say with abdominal pain, we should be wearing some form of protection and they should also be wearing a mask. This would be the same feeling of concern that primary care, carers, district nurses have, that we should institute an attempt to break the chain of transmission by putting in both the masks and the attitude around hand hygiene, surface cleaning, and all the rest of it. We then come to our other big concern, which is the higher risk patients. So patients in our suspect but don't know yet because we can't get a testing result within the time frame of an emergency department visit. So we have patients who, to be absolutely honest, are blindingly obvious they got it. We're still not perhaps as well protected as we should be. We need to be able to wear what are called FFP3 masks and this visor that Paul mentioned to absolutely prevent healthcare workers being affected. We understand high-risk areas in ICU and HDU, that makes sense, and we wouldn't want to downgrade that concept at all. But by that time, very often the patient's result is known, you know the risk you're dealing with, and we do understand ventilation disconnection risks. But in an emergency department, when you've got a coughing patient, you've got an agitated patient, you've got a patient who doesn't understand wearing a mask, you have the risk of a mixed environment where you're putting healthcare workers at risk. And it's got to be the primary responsibility of everybody to make sure that we maintain our workforce in this difficult time, that we make sure that they're absolutely protected, but that they also don't become a cause of transmission themselves because they're working when they have picked something up, but they're asymptomatic and they're only going off when they finally develop symptoms.
Thank you. And Chand, you're obviously getting a lot of messages from your BMA members. What's your perspective on where we're at?
So we are flooded with anxieties, concerns by doctors. It's the single biggest issue at the moment. And we have two concerns. One is the actual supplies themselves. And I know we've had assurances around deliveries being escalated, but that we're still finding far too many of our members telling us that that hasn't translated on the ground. And even this morning, I've had emails from doctors saying that masks have run out, they're having to wear them for longer than they should, and so forth. But there is the issue of supplies. In general practice, when we run out and we ring up the helpline, we're told to actually buy them ourselves. That is the advice we're getting. So there's still an issue of supplies, but I accept there is an increase. The other issue is about the adequacy of protection. And if you look at the World Health Organization's recommendations for any healthcare worker, and I speak for nurses, ambulance crew, because they have the same concerns, as a minimum, a healthcare worker should have their eyes protected, because we know that these droplets can be absorbed through the mucous membranes of the eyes, and also to have protective gown. And we have neither of those in general practice, in the community, nor for that matter, frontline staff in A&E. We are given a plastic apron, sleeveless. I wear normal clothes at work. My clothes are exposed. They could be infected. I take off the apron, see another patient. I may be harboring infection. This just doesn't seem this doesn't seem to be the standards we should be adhering to. And it's not just the WHO, the European UAMO, the European Disease Communication Center, are all recommending the sort of protection that the WHO speaks of. So we have concerns on both fronts, adequacy and supplies.
Thank you very much. I'm sure we'll bring you back, but can I just ask Professor Doyle, just to clarify that particular point, is Public Health England guidance on PPE equipment weaker, or is it the same as World Health Organization guidance?
Chair, it is consistent in the vast majority of the guidance. It does differ though, and we've done an analysis ourselves of the coherence of the guidance with WHO, CDC in Atlanta, and the European Disease Centre. And there isn't agreement between these agencies on many of the equipments that should be used particularly in the most risky settings. So there is a problem here, I think, about everybody agreeing what the right thing to do is. What we would say with the guidance here, which is jointly, it has been inputted by the NHS, it's been penned by clinicians, and it has been advised by our advisory groups on dangerous pathogens and emerging viruses, is that it is more protective in the most risky environments than what the WHO recommends. There is a difference in other settings, and the reason for that difference is that the guidance has been written on the basis of best infection control, which has served this country for many decades. And I know the issue that comes up occasionally is bare below the arms and the apron versus the gown. And the reason for that is that we want to ensure that other hospital-acquired infections are not actually the thing that kills the patient. So there's a balance here between what we're doing for the coronavirus and what good infection control has told us works for all infections in hospitals. And that's building on experiential evidence. I wouldn't try and pretend there's a huge amount. There is a literature review and we've got it, but it isn't as definitive as perhaps people might think it is about what exactly to do in each setting. What the WHO recommends is a proportionate and rational approach to infection control. And the third element of this is that just having a piece of equipment is not going to protect people fully or patients. It is a whole system approach to best infection control, as people have mentioned. And I don't need to labor that, but I think what we're noticing is that this hasn't actually been at the top of people's minds up to this year. And perhaps people are very anxious, which I think I absolutely accept because we're hearing it as well. But we do really have a training issue here and a communications issue, as Chand has mentioned, as well as simply just having, the piece of equipment that people think will fully protect them.
Can I just put to you, this is what Chief Executive of an acute trust in the Midlands told the Health Service Journal. This Chief Executive said, "There is a near revolt amongst my clinical staff about the national guidance on the use of surgical masks for non-aerosol generating work. They see hazmat suits and FFP3 masks, the highest grade of masks, being deployed in all scenarios in Western Europe and want to know why we aren't doing the same." That's not an unreasonable thing for staff to feel, is it?
Absolutely, I accept people's anxieties, but I don't know the circumstances in which they saw the hazmat suits. But I come back to the point that the guidance, which has been cleared and written by people who actually live infection control every day of the year, the guidance is proportionate and protective for the most risky environments. In this circumstance, I think I fully accept that it's guidance that's under review, and in the light of people's anxieties and the full package of the problems that are emerging here, which are not just about one issue really, we are keeping that under active review. Indeed, it is right now.
So let me just ask you about something that is in your guidance, because you're now very clear that if there's a risk of spray of someone, for example, coughing the droplets, then the healthcare worker should wear goggles or eye protection. And obviously at the moment, there could be up to 500,000 people infected around the country if it's still about 1,000 cases for every death. So that's a lot of people out there. So that wouldn't just be for people in ICU or in the COVID-19 cohort areas. That would apply to GPs, for example, district nurses, people in A&Es as well. They should be wearing eye protection. Is that correct?
Well, again, this depends on the clinician doing a risk assessment in their setting as to what exactly is the likelihood of getting droplet infection in the procedures that they're undertaking. And yes, if an aerosol generating process has been undertaken in a setting, the right equipment should be used for sure.
You are a doctor and you are the medical director of Public Health England, so it's not unreasonable for me to ask you, given your knowledge of the work done by people in A&E departments, should they be wearing goggles?
Well, certainly they should be undertaking a risk as to what the likelihood is that they will be within a metre of some, because that's the droplet distance. A metre is what a droplet travels in. Obviously, doctors who are at close quarters, yes, they need adequate protection for that, but that does depend on the risk. It isn't a unit.
They are going to be within a metre, and a GP is going to be within a metre of a patient, and a nurse, community nurse, is going to be within a metre of a patient when they visit them, aren't they? So they should be wearing goggles. That's what could you just give a straight answer? Because that is your advice, that if there's a risk of droplets. And so just those three examples, GPs, community nurses, A&E, doctors, should they be wearing goggles?
If they're in a situation where transmission is likely to occur, of course. So droplets, aerosol, and touching are the three ways in which this particular virus is transmitted.
Okay, and can I just ask Chand then? I'm so sorry, but can I ask you, Chand, have they got those goggles, those three categories, to your knowledge?
So the Public Health England pack that GP surgeries have received comprises of gloves, a mask, a paper surgical mask, and a sleeveless apron. There is no goggles provided. In fact, there are many GPs who are trying to get hold of them online, but the stocks have run out. As I said earlier, not only that, we have no other covering of our clothing, and my own practice as well as others have tried to buy some online, some surgical scrubs. That's the sort of desperation that we feel, because we have risk assessed, and we believe we're at risk, and we're risking the health of patients if we're not at least covered and we don't have our eyes protected. And many, as you said, are visiting patients at home, very close by. We've got GPs now going into what are called COVID hub centres in the community, where patients with COVID suspected symptoms are being seen, and they don't wear gloves. So we're not even being provided them.
Dr. Henderson, can I ask if your members have got the goggles they need?
So it's very variable. We're rather than wearing goggles, we're wearing visors. And at the moment, visors are being worn when we're very close up to a patient in our resus rooms. But we're not managing that in our high risk, intermediate risk areas. We feel that that would be the most sensible thing to do. We feel we need to do this at a higher level than maybe the evidence gives us. We recognize absolutely the evidence is difficult. We also recognize completely the logistic problems of all of this, but it would be good to hear about the production and call for manufacturers to be making face shields, visors, whatever you call it, and masks in the same way as we're hearing about ventilators. If we can stop the train of transmission, by getting all of these bits right, and we absolutely recognize that it's not just about single items, it's about the whole system, and it's about how we take our things on and off and prevent ourselves getting infected, how we use our gowns, how we do wash our hands and arms properly, how we cohort our areas. But increasingly, our A&E departments are pretty much full respiratory. So my department that started out with a sort of minor division is now, the whole of our majors area is now a respiratory area, and our old observation ward is our, in theory, clean, non-respiratory area. That's not going to last. We just need to assume it is everywhere. We need to have some degree of protection, and in the highest risk areas, bearing in mind the logistics and that we're in this for the long term and that we need to keep stocks, use as high a grade of protection as we possibly can, and absolutely ramp up the production of it.
Thank you. And I'm going to bring in my colleagues now, but I just want to ask Dr. Tanto, if I may, on eye protection. What's your experience on the front line in terms of the availability of eye protection in the work you do?
It's similar to what Dr. Henderson's just been saying. For the higher risk patients, there's an availability of visors. Some staff members have used goggles, but visors is the recommendation. There have been issues of visor supply, certainly in the earlier stages of COVID-19. I think that's starting to ease. Much like Dr. Henderson's hospital, we're also major part respiratory division in A&E in the hospital, another part non-respiratory. And we do make, much as what Professor Doyle is saying, a risk assessment about the likelihood, the severity of COVID in patients who are coming in with respiratory symptoms. Thus, those who are walking in probably are seen by doctors not wearing visors, whereas those ambulance conveyed to hospital, more severe symptoms, are visor greeted. It would be welcome, and I echo Chand as well, it would be welcome to have a surplus of visors so we aren't having to make risk assessments for the use of visors. It would be nice just to have visors for everyone with a respiratory symptom in the initial stages until we get greater clarity in who is and isn't COVID positive.
Thanks now, and I think Dean wants to come in first because he actually wants to ask on eye protection. So Dean, over to you.
Thank you. So I was going to make a similar point about, making sure pharmacists and other groups, you've got supermarket workers, for example, who are going to be seeing lots of people. Should they be having eye protection? And the other question I had related specifically to eye protection and the creation of it was that I've seen people popping up on Facebook saying they're going to Hobbycraft and buy materials so that they can help make visors and so on. When I've gone into B&Q for DIY stuff, there's used to be stocks of goggles for DIY. And I just wonder, is there any initiative to look at, of course, going out to factories, but could there be an initiative to get people to help from home, that if they get the raw materials for building very basic visors, they could potentially, or even donate goggles they've got. I appreciate they'd need to be cleaned and properly evaluated, but surely we could get an army of school kids who are at home to do a bit of DIY work and build very basic visors and so on to help with this, so that we have got a surplus. It's that classic thing of, it doesn't need to be perfect and it's good rather than great, but at least for some of the, even if it's not the NHS workers, to help the wider groups with visors or goggles.
Thank you. Just before we answer, I'm going to ask Professor Doyle and Chan Nagbal to answer those points, but Laura also wanted to ask about eye protection.
Yes, thank you very much, Chair. I wanted to echo the comments made by others in terms of the availability of eye protection, particularly for GPs. And I just wanted to be clear, GPs in my constituency at the moment have not received any form of eye protection. When are they going to get this? Thank you.
Thank you. So Professor Doyle first.
Yes, so just to go back on a couple of the points made. So the guidance will actually support the use of eye protection with a risk assessment as to whether you're likely to get droplets into your eyes. And I just continue to support that. I understand the points about, could we not just get more supplies? I know that there is work in hand to ensure there are supplies, and there are millions of these respirators available at the moment, but this may, in the light of what is coming back from the field, again an NHS issue that will have to be assessed. But I don't think there would be a lack of willingness to hear those concerns, Chair. In terms of making them, there is another element about this, which is they do need, as I understand it, proper training to fit them adequately, particularly the ones which are in the highest risk settings. So if not properly fitted and not properly designed for fitting in the way that they're intended to, they don't protect. But I think it is very welcome, again, if people are offering to help and support with this. Thank you.
Thank you. Chand.
So the difficulty we have is that the World Health Organization, it's a piece of paper sitting in front of me, is very clear that a healthcare worker like a GP, a primary care physician, should be in receipt of protection comprising of eye protection, a gown, and gloves and a mask. The supplies as specified by Public Health England and as supplied by the NHS does not include any eye protection for GPs or primary care workers, does not include a gown. And I know we're speaking about eye protection, but let's not forget our clothing also transmits and can be a carrier of infection. So we're not receiving, it's not even specified that we should receive the protection of the World Health Organization's recommendations. And for that matter, the same applies in Europe. They've made the same recommendations as the WHO. So we seem to be an outlier here, and naturally, not just GPs, but nurses in the community are very, very worried that they're not adequately protected.
Thank you. I'm going to bring in Sarah Owen next, and after that, James Murray. Sarah.
Thank you, Chair. The questions relate to the concerns that Dr. Nagpal and Dr. Henderson have raised. The first one is around, for Professor Doyle, there is clearly a mismatch now between the kind of more optimistic messages coming from the government and their briefings to the actual reality of what's happening on the ground in terms of supply of PPE. Chris Whitty had said that supply chains were an issue. How far are we away from clearing up those issues? And how is it being prioritised in terms of who gets the PPE first? Is it hospitals? Is it the dedicated COVID-19 centres that we're seeing set up? Is it GPs, paramedics? Or as Dr. Henderson said, it's really important to have social care workers and primary care workers also having access to PPE. So who is taking the decision on how PPE distribution is actually being prioritised?
Oh, sorry, you seem to be, you're the government representative here, so that's why you're getting the questions. We do appreciate that, and some of these will be outside your area, but if you could help us as much as you can, it'd be appreciated.
Yes, thank you, Chair. And I do welcome this, actually, because I will certainly convey this to the colleagues who need to hear it as well. So that's fine. So the guidance, to go back to Chan's points, accept it entirely. This is not an attempt to undermine general practice. The guidance is actually more orientated towards the context of what is being done and where the risk is, and particularly where the procedures of the highest risk are. And whoever is involved in that higher risk, the guidance is very supportive of them having the appropriate protection. And it keeps coming back to, I think, what one of the other speakers said, is that risk assessment is very important. And indeed, to accept the issue about supplies as well, the priority there, it is understood that there's a lot of anxiety, not just in hospital, but in the communities and in social work. And we also accept that those who are at any risk in the community should have equivalent access to protective equipment. So it's not as if the health system in a particular setting would be more important than the social care setting. That is definitely a challenge, but it is an accepted one.
Okay, thank you. James Murray, and then after that, Rosie Cooper.
Thank you, Sharon. And I'd like to ask two questions. The first question I'd like to ask to Dr. Tanto, particularly given his experience working at Northwood Park. And Northwood Park served many people in my constituency, so a particular thanks to him and his colleagues for the work that they do there. But we know that Northwood Park had a critical incident declared at the weekend. We know that on Tuesday, over a quarter of the deaths registered in England from COVID-19 were in the London Northwest Trust. And so what I'd really like to ask from Dr. Tanto's experience there on the front line, does he have a view on why the numbers from Northwood Park and from the trust which is part of are so high? Obviously that's a concern for people living locally, but also what can we learn from that in terms of the general response to COVID-19 outbreak?
I think there are two issues about the statistics. I think the first is a hospital issue and the second is a geographical territorial issue. The hospital issue is that Northwick Park is a centre of specialty for infectious diseases with some notable clinicians who work there. The consequence of that is that Northwick Park has taken COVID patients from other parts of the country to Northwick Park for infectious diseases treatment. I think by definition they will be iller than elsewhere, and as a consequence, as we all know, iller patients have a higher risk of mortality, and I think that's one issue. In terms of territory and geography, the Harrow-Brent area of northwest London has a significant number of houses of multiple occupancy. With that, you have non-family members who are all living and working in a probably smallish housing stock, who are working at Heathrow, they're working in service industries, and they're coming back, and you're getting a lot of commingling. There are also quite a large number of intergenerational households where you have grandparents, parents, children, grandchildren all living together, and you have the confluence points of interdependence of exposure to COVID in the community coming in, mixing under the house and then mixing out from that. These issues, I think, allow for a greater penetration of COVID within the area, and then as Northwick being the hospital there, you'll see a greater number and statistics of COVID patients presenting. We also have quite a degree of frailty in our community in Harrow Brent. There are a lot of patients with heart and lung conditions, certainly a respiratory team of excellence at Northwick as well. So people with respiratory conditions already are going to be slightly more vulnerable to COVID infection. And I think that adds into the statistics as well. The critical incident was because there was a surge requirement for intensive care beds. Now the hospital's making more intensive care beds available from its baseline, and as that comes on stream you should see less of it. But there's certainly going to be an increase in demand over the next weeks to month for intensive care beds. So we are in a difficult situation in that respect.
Thank you. Did you have another one, James?
Yes, I just had a very quick question to Professor Doyle, if that's okay, which is we heard from Keith Willett last week around the NHS and being able to draw on the pandemic influenza stockpile for certain elements of PPE. Now, thinking about his comments there, it struck me that if you had a pandemic influenza stockpile of elements of PPE, you should naturally have a distribution chain to get that out quite rapidly. But it seems to be that the problem has been the lack of that rapid distribution. So why would we have had a pandemic stockpile of certain elements of PPE, but not the distribution chain to go with it?
Well, thank you, Mr. Murray. So that is correct, and the pandemic stockpile is being used. Partly, I think this is complex logistics, and I don't pretend to fully understand the answer to your question. But I think partly it is about the uneven distribution of the cases themselves, and where people, and we can see this now that certainly the analysis of both cases and deaths by region shows different patterns at the moment. It may simply also represent where trusts particularly needed additional supplies that perhaps they hadn't realized before. So it's very difficult to answer that question, but there is a distribution chain, and in fact, press releases went out to say, this is how it's going, and if you can't get access to it, ring this number. And I think that did improve, but we're still not completely right, I'm sure.
That's very helpful, but just to understand this very specific point, there is this pandemic stockpile of certain items of PPE ready to go. Was associated with that a special rapid distribution plan for that stockpile?
Yes, I believe so. Again, it's something that I'm not day-to-day involved with. It would work through the NHS, but yes. And I think that the distribution was ramped up considerably when it was realised that actually certain places were not getting what they needed. Okay, so there was a rapid distribution plan, it just hasn't worked. Well, there was a distribution plan, but it's always, no plan survives battle, really, when it becomes clear where there are different levels of supply already in stock. And I think that may be what happened, but I can't answer any more than that, I'm afraid.
Thank you. Rosie Cooper, and then after that, Luke Evans. Rosie, have we lost you? Let me bring in Luke Evans, and then we can come back to Rosie. Luke, can you ask your question?
Thanks, Chair. I have two questions. The first one is to Chand, if that's all right. I'll ask that one, and then I'll ask one to Yvonne, if that's okay. Chand, I spoke to my CCG yesterday, and there seemed to be some confusion from GPs coming up over what the best models are. Did the BMA have any suggestions on whether hub and spoke models should be working, PCN models, and do you feel the guidance is clear enough over how to use resources? Because if you had 3 practices close by, setting one up as the COVID centre with PPE equipment may well allow you to carry on normal GP activity and also COVID-19 activity. Do the BMA have any position thoughts on the continuity of the message that's coming through?
Well, I think it's so good that someone's raised the fact that there are many ill people out there who are not COVID sufferers, and the health service must be providing a service to all of them. So what we think is important is for GP practices to effectively be clean areas, so that the patients, the public who come into our surgeries feel safe, that they're not mixing with ill patients with respiratory symptoms. So in that sense, having a hot hub would be a very sensible model that I would support. We don't have a BMA position on it, but we certainly have a position on having clean and hot hubs, if you can say. But that goes back to the protection, because the GPs in my patch, where we've just set up a hub, are worried about the PPE. So it goes back to that. So if we could provide those GPs with the eye protection, with the gowns, so they actually felt when they were doing their jobs, they were protected, that would enable those hubs to take off. So I absolutely agree with you about separating clean and dirty areas.
Thank you. My second question is to Yvonne Doyle. There's two parts to this. The first is, with regards to advice on high-risk people, there's ENT specialists, dentists, and ophthalmologists are very, very close to people's eyes, nose, and face, obviously. Is there any difference of advice for them and special precautions? Because they really are right in the front line.
Thank you. Sorry, I was frowning because our fire alarm just went off there. But yes, so again, thank you for that. Yes, aerosol generating procedures, they're reckoned to be parts of dentistry. And indeed, there's a list of procedures, and it would include anything that ENT did in relation to suctioning, and certainly anything respiratory, a list of respiratory procedures, which are reckoned as very high risk. And in those circumstances, the full PPE should be worn, including FFP3.
Thank you. Now, to follow that question up, because I think this one's a really important one, can you be clear on the advice? Because if someone is exposed front up, a GP looks into someone's throat and this person does have COVID-19, what is the response that healthcare clinicians should do? Are they to self-isolate for 14 days? Are they to go for 7 days? Because the worry is the workforce, they don't know how to react to this. And I'm not sure the message has been clear. I was on the phone call with the police yesterday. They face a similar idea. They're getting people spitting at them saying, I've got COVID-19. Now, I don't expect you to comment on the legal aspect, but the worry is, if this is happening, what is the advice for someone who has exposure? What is significant exposure? And what should the advice be?
Well, droplets and aerosols are significant exposure for certain, and touching with hands that are maybe contaminated also, which is why the washing hands thing comes in. For healthcare workers, people do not isolate unless they have symptoms. If they have symptoms, they definitely need to isolate, and they isolate for 7 days. The 14 days period is where families are in touch, and I do accept this can be confusing, and it does take people out of the situation, and it comes back to the issues of testing, which we fully accept. 14 days is where a member of your family has been exposed and is symptomatic. And the reason for that is that by the time you actually get to be in contact with them, perhaps you may be incubating the condition yourself, and that gives you another 7 days. It does end at 14 days. But for people in healthcare settings, the advice is, if not symptomatic, don't isolate.
So can I just be crystal clear on that? If I'm a GP, I see a patient who gets confirmed COVID-19, what is the procedure that I should follow?
Well, I think there is a risk assessment as to whether, if the person has been deemed positive, you will need to be followed up carefully to ensure that you don't develop symptoms. I think the advice would be to watch for symptoms, and the most important symptoms are fever and cough. And then at that point, the assumption is you should immediately self-isolate.
Thank you. Chand, I think, wanted to come in then.
I just want to understand the logic there, because if a doctor, and we've had many doctors who've been worried that they've been in contact with COVID-19 patients without protection, the example you've given, if you're waiting for the symptoms, then in that intervening period, you could be passing on that infection in the incubation phase. How does that tally with the advice we're giving around self-isolation if a member of your household has symptoms, let alone being COVID positive. So is this not therefore resulting in the risk of spread by healthcare workers not self-isolating in contact with proven COVID-19 patients?
Well, again, I understand the difference here. I think the healthcare worker, this is a balance between the healthcare worker understanding the level of risk and keeping at work. And we've certainly taken advice from clinicians on this. And somebody in the lay community who may not, and we're overly precautionary about, particularly in the family setting, but I do understand it sounds different. I think if people feel that they are, certainly if they are at high risk and they are uncomfortable about continuing to work, and certainly if they're developing symptoms, they should self-isolate. So this is not absolute. It is the best guidance in the circumstances of where we're learning about how this virus behaves, particularly before people are symptomatic.
Dr. Henderson wants to come in on that one, and then I'll move on to Paul Bristow and James Davis.
So one of the issues is that I have enormous sympathy for the GP's position, but to a certain extent, a GP surgery can decide what rules it's going to play by. And it can decide what kit it's going to get. I know some stuff is being sent out, but they can make certain decisions. Emergency departments and the front line of the NHS have to follow the central guidance. So we have hospitals where it's being said, you must follow the current guidance. We don't have the option to perhaps risk assess in quite the way that's being described. We have the kit available. That's the kit you've got available. We are, to a certain extent, trying to make sure that when there is a risky situation, we get kit that is appropriate. But basically, we've had people being told that there will be serious consequences if they don't follow PHE guidance as regards kit. So we don't have that luxury to go, ooh, this is a bit more high risk. We need to just protect everybody as much as possible, proportionally from the beginning, so that everybody has something, and then be able to ramp it up when it becomes apparent. And currently, the resus room of an A&E department is not even thought of as a high-risk area unless there is an aerosol generating procedure going on, at which point, yes, everything is being followed. But we're not doing those in single rooms. These are now in open areas. So there is a problem with proportionality. There's a problem with risk assessment. There's a problem with how we communicate to staff how at risk they are. We need to be able to know that there's going to be some protection for everybody who's coming into a hospital or having an encounter with a healthcare worker. And we need to understand that the nervousness is really real, that we become part of the problem as well as part of the solution.
Thank you. Paul Bristow.
Thanks, Chair. There has been a recent downgrade in Ppe requirements from WHO standards, and this is outlined in a document called COVID-19 Guidance for Infection Prevention and Control in Healthcare Settings. If the evidence for this downgrade is there, why do you think so many NHS staff are unhappy? Why don't they believe Public Health England?
Yes, well, thank you. It's a really key question. So the downgrading wasn't an attempt to underestimate COVID itself, but really a learning of how it is behaving, which it looks much more like flu than some of the conditions like Ebola, where initially people were not certain how the virus behaved. And the assumption has always been that 80% of people will actually get better and very quickly from that in 7 days onwards, and that there would be then a severe tail. So when that was better understood, the 4 countries, and it wasn't Public Health England, the 4 devolved administrations and the NHS, in conjunction with the right expert committees, took the view that it was proportionate and reasonable to change the status from high infectious consequence infection to the status it has at the moment. But the equipment and the guidance in relation to that does still very much approach where the risk is likely to be. And we've taken advice collectively between the NHS and Public Health England on that again, and we will continue to do so. So it is a risk-based approach to that. And sorry, your question was why is it anxiety? Yeah.
Yeah. Why don't they believe you? Because I can tell you, kind of firsthand, what I've heard is, quite honestly, they believe that Public Health England, or at least the NHS, realised there wasn't enough FFP3 kit to go around, and that was the reason for the downgrade.
Yeah, I think that's very helpful to say, because that was not the reason for the downgrade. And again, this is a learning experience for everybody, and I do absolutely accept that how people behave and what they're feeling anxious about is something that we have always felt would be a part of the learning from this epidemic. And this is, this continues. So this is not forever. The guidance is reviewed regularly in the light of practice, and I'm sure that it will continue to be the case. Why people are anxious, I think there's a complex set of reasons for this. And partly it's the unknown, partly it's the real problems that people have experienced maybe in having supplies, and partly it is an unfamiliarity with day-to-day infection control.
Okay, all right, thank you.
Thank you very much. James Davis.
Thank you. My question would be about communication above all else. I've read the documentation from the public health bodies in the UK, but there are a lot of people out there in the community in particular who don't really know what they should be wearing. For instance, occupational therapists who are wearing still their usual uniform, no form of protection. Admittedly, this is in North Wales, not in England. Community nurses doing the same. And they feel very much on their own, and what I haven't seen is simple guidance, a flowchart or graphical illustrations for the hundreds of thousands of people going into homes daily for social care and so forth, for those people to know, are they doing the right thing? Are they being given the support they need from those around and above them? And they are in a different position to those working in hospitals, where there are often supportive teams and infection control support there at hand. Thank you. So that's to Professor Doyle, and also to Chan Nagpal, whether he would agree with that, really. Thank you.
Yes, I think absolutely, and actually Public Health Wales were involved with this guidance, and will continue to be so. So I think this is absolutely right. I think the communication and training and making it easy for people to understand what to do, rather than every sort of profession having to have bespoke guidance, but just trying to get out there, in what circumstances could you be at risk in your professional practice, is by far the better way to do this. But it needs, I think, much more education and opinion leadership than we have at the moment anticipated. So I completely accept that. I think the clinicians involved in all of this would accept that too. Public Health England has commissioned some support to offer training, and has done posters on donning and doffing. And the greatest risk is taking things off and taking it off the wrong way, and self-contamination. So this is stuff that we will continue to offer support for. I accept your point. I think it's right. Communication of this is paramount.
Chand.
Yeah, so I wrote to Public Health England yesterday, so I still will maintain that the guidance and the equipment offered for low risk situations, if you can call general practice and A&E front end low risk, is still not the same as that recommended by the WHO. And I'd quite like a clear answer to that. But I also agree with the comment that we are working in a health and social care system. We're going to, the plans are for patients to be seen increasingly in the community, to discharge from hospital earlier. And I do worry about our community nurses. I do worry about the volunteers and social care workers. They also must have proper protection, and they're equally at risk, not just to themselves, but also of spreading infection. So when I'm speaking about protection, I'm speaking for doctors, but I am speaking for the wider healthcare community and social care community, who have expressed exactly the same concerns.
That's a very good point. I just wonder if Professor Doyle could tell us, because this was a question that Taiwo Owatemi wanted to ask, which is these 400,000 volunteers, what are we doing to keep them safe in terms of protective equipment? And also, question from Sarah Owen, what work are you doing with care companies and care homes to make sure that they are getting the right advice and the right equipment for the work that they're doing in the community?
Yes, so the volunteers are for the NHS, and I think the answer to that will be that the NHS and with our support will need to consider in what circumstances they're being deployed and what the risk there is, and indeed what the protection for them will be. And that will be a huge, a massive, I think, logistics exercise to make sure we get that right and give people the confidence to keep volunteering when they're generously offered, Chair. And that is work, that would be work in hand, because this is very recent. But it comes back to the circumstance of exactly what are they being asked to do and how risky and how much risk does that incur for them. In terms of this social care, so we have provided guidance on social care and for people working in the social care setting and for indeed informal care. And I did say before that we accept entirely that social care needs good consideration according to the risk that they are at alongside other frontline workers. So, and there's plenty of advocacy for that within the system. So I just want to assure you that they are not, we don't lose sight of that. Again, it's what is appropriate for the risk that they're facing, particularly in care homes. I understand that point. And Chand, yes, just to acknowledge, we did receive your communication and we will be responding appropriately and fully to that, and thank you for it.
Thank you. And I just wanted to wrap up because we do now need to move on to our second panel, but just one last question. I know you can't give me an answer now, Professor Doyle, but could you commit that by the end of tomorrow you can get back to us and just get to the bottom of when GPs are going to get the eye protection in particular, but also the gowns that they need? Because this is something which is obviously a huge concern. We obviously want to know about community nurses and other healthcare professionals, but particularly for GPs, not just because Chand is a GP, but just because it's been raised by so many people. Could you talk to your colleagues in the NHS and the Department of Health and Social Care and just get back to us with a very specific answer about when we're going to make sure that all surgeries have all the equipment, including the eye protection that they need?
Yes, Chair, I will do that.
Thank you. Well, look, it's been a longer session than we planned, but I think these are very, very important issues. So I'd like, on behalf of the committee, to thank you, Professor Doyle, for answering so many questions, such important issues, but thank you for your